Good afternoon, everyone. I welcome you all the participants, speakers, and advisor QPS team, and also our colleague Dr. Siddhi and IT team for this ninth online STG lecture series. Today we have two technical sessions. One is on adverse drug reaction, identification and management by Dr. Sangeeta Sharma, and another technical session is on post-operative care of cataract by Dr. Jolly Rohatgi. Now, I would like to request Dr. Jain Srivatsav, Sir, Advisor, Quality and Patient Safety Division, to address the participant and brief about the STG lecture series, which was started in the month of August 2022. Sorry, September 2022. Over to you, sir.
Thank you, Dr. Annapurna. A very good afternoon to Professor Sangeeta Sharma, Professor Rodgi, all the colleagues who have joined online, and my team colleagues from IT and from the QPS who have joined over here. A very warm welcome, and it is heartening to see that on Saturday about 95 odd participants are still there, because some time back, like NHSRC and Delhi Society for Promotion of the Rational Use of the Drugs, we have been concerned as such in the country that how do we improve the quality of care, and within that the clinical care, because a lot of care gets delivered at the peripheral level, where more often than not either there is one specialist, one doctor, even one CHO at the health and wellness center, and who is tasked with the looking after the given population. There are hardly any avenues for refreshing the knowledge, and the person starts working in a typical mindset. So with this background in mind, both these partners, Delhi Society for Promotion of Rational Use of Drug and NHSRC, came together, and this is the ninth, in fact, the topic which we have chosen to work together. The main objective of these sessions are that refresh the knowledge, build the capacities, in general, improving the prescribing habits, improving the clinical care, and within that ambit, we all know that India, being one of the developed or developing nation, that one can always debate, but still globally we have the substantial chunk of people having the visual impairment and the blindness. I will not go into those details of the technical definitions for which we have got the experts. They will be talking. But the Ministry of Health and Family Welfare has been running a program, and within that ambit, lot of targets have been set in for, because majority of the blindness, visual impairment is because of the cataract. About 60 to 70% of the people, largely they have. And cataract, my mind, experts may differ from me, that to my mind it comes that the only option becomes surgery. And I still recall during my early days and how the surgical practice has changed. It has become less invasive, but still the government has set a target that for 22-23 it was about 7.5 million surgeries, subsequently about 9.5, and the subsequent year about 10.5, because the program suffered certain setbacks during the COVID period. With this much of the workload coming up, there is a substantial responsibility on the shoulders of our CHO, primary health medical officers who are posted at the PHCs, even in district hospital and CHCs as well, because a lot of surgeries take place during the camp approach, particularly in the northern region. There is a notion that surgery, let's get it done during winter months. So there is a sudden influx. and for the post-op care, which becomes a critical component to have the better outcome of the surgery. And this was the topic chosen in this direction. We have got today, though, Professor Sangeeta Sharma would, introduce the speaker, but very eminent speaker, Professor Jolly Rohgi, who has been an academician all throughout and has done substantial amount of the work, though her specialization is glaucoma, then neuro-ophthalmology, and any ophthalmologist who is there in the field, obviously the cataract becomes one of the mainstay of the surgery. Ma'am, correct me if my perception is not wrong. So we are privileged to have you, ma'am, and we certainly look forward to your work of wisdom, particularly for the messages for our peripheral or the grassroots level functionaries, whether the doctor or the community health workers, even certain people who are working in the vision centers in district hospitals, that what they can do, what they should not be doing. And again, as I have mentioned in my earlier conversations with you in the previous 7 to 8 lectures, that I must acknowledge and gratefully we remain indebted and grateful to Professor Sangeeta Sharma, who single-handedly leading this initiative in the mission mode. So without much ado, I will be stopping over here, and thank you very much once again. Thank you, Annapurna.
Thank you, sir, for addressing the participant and briefing about the STG lecture series. Thank you for your word of wisdom. Now I would like to request Dr. Sangeeta Sharma, Professor, IBAS and the President from DSPRD, to take the session on identification and management of adverse drug reaction. Over to you, ma'am.
Thank you, Annapurna. Thank you, Dr. Srivastava, for your warm introduction to the subject here and this initiative. In this session, we have chosen. There is a problem in sharing. There is a good network connection, but it's, I don't know. Annapurna, there is a problem in sharing from my end.
Ma'am, I'll share you, ma'am. Please send.
No, I didn't send you my PPT. But why is it not coming?
We'll cross check here.
Call Mukesh.
Let me try once again.
Please re-log in, ma'am.
And just a minute, let me try. Can you see my screen?
Yes, ma'am. No, ma'am.
No.
No.
Not yet.
No, ma'am.
Normally, there is no problem. I've sent you my PPT. Okay, let me log out and then I'll log in again.
Oh, okay, ma'am.
Yeah, now it has come. I hope you can see my screen now.
No, ma'am. No, ma'am.
No, now it is showing that I'm sharing my screen. Okay, then you share from your end, I think.
Okay, ma'am.
There's some problem today. Share, when I say share content, it is just going round. Okay, meanwhile, while she's uploading, we have chosen this topic, adverse drug reaction, because this is a substantial problem that we encounter every day. Most of the treatment that is given, medicines, and all medicines, when they have effects, they also side effects too. So they this is one of the important reasons that the many patient harm occurs because of adverse drug reactions. So the Sir William Osler, the father of medicine, modern medicine, he said that the person who takes medicines must recover twice, once from the disease and once from the medicine. So that means that we need to use these medicines properly, weighing the benefits and their risks, because dying from a disease is sometimes unavoidable, but dying from a medicine is unacceptable. So no patient harm should happen because of the adverse drug reactions. Largely, although these adverse drug reactions cannot be prevented because they are related to the inherent nature of the drug, some of the side effects happen because of their mechanism of action. Most of it cannot be avoided or prevented, but certainly the extent of harm can be reduced, or the risk can be mitigated if we identify these adverse drug reactions quite early in the management of the patient. The most worrisome, which adverse drug reactions which go unrecognized are because of the prescribing cascade. This is what happens every day. Patient presents to you with some problem. For example, patient comes to you with a hypertension, and you start the patient on an antihypertensive drugs, and as the treatment continues, the patient develops pedal edema or swelling in the body. uh, if we do not recognize this, very often it happens that you prescribe another drug to clear this fluid from the body, to clear. So often thiazide diuretics are prescribed for the same. Now, because of this thiazide diuretics, there may be overactive bladder in some patients. So another drug is started, prescribed to treat this overactive bladder. So then this third drug C, causes another side effect. You prescribe another drug for this drug. So that's how the number of drugs prescribed per prescription goes on increasing. And this not only happens, this is just one example. Hypertension, very often, patients, old patients, elderly patients with osteoarthritis, they are getting this non-steroidal anti-inflammatory drugs, analgesic agents. So again, fluid retention is one of the prominent side effects of this group of drugs. So this fluid retention leads to hypertension in this patient. So then, because BP is high, antihypertensives are started. Similarly, if you see in my own hospital here in neuropsychiatry practice, antipsychotics have a prominent extrapyramidal side effects, where the patient gets symptoms like Parkinsonism. So once the patient develops those Parkinsonism symptoms, they start getting anti-Parkinsonian medication. So that's how this cycle goes on, and this is called prescribing cascade, and it leads to polypharmacy, where the number of drugs to treat a majorly healthy patients exceed 4 or 5. We will be discussing about this polypharmacy in the next session. But this part, prescribing cascade is mainly because of the adverse drug reactions that we see with these medicines. Now, the attention to this subject was brought by the thalidomide incident in 1950s and 60s, where more than 20,000 children who were born in 46 countries, they were born with deformities called phocomelia. This drug was mainly used in pregnant women for sedation in these patients, and it resulted in a major deformity called phocomelia. So that worldwide, then all the drug regulatory authorities, they got alert to this, and the need for pharmacovigilance was felt. So systems and the standards, processes were set. Pharmacovigilance is nothing but a science and activities related to the detection, assessment, and understanding and prevention of these prevention of the adverse effects. So, because there are two main concerns, whenever we are treating the patient, safety is must, and efficacy of the drug is a real concern here. So, the pharmacovigilance, this, takes care of the patient care, and tells us about the best use of drugs and medications for treatment or prevention of the disease without any undesired effects. Now, before I go into the details of the adverse drug reactions, let us first understand what do you mean by adverse drug reaction. So, any unintended, undesirable, or unexpected effect of a prescribed medicine is called an adverse drug reaction. So which, because of this unintended, undesirable, noxious, unpleasant, unexpected effect on a patient, sometimes you may require to discontinue a medication, or modify the dose, or you need to limit or prolong therapy, hospitalization. It may result in disability, or life threatening. It could be life threatening in some instances. So this is, whenever this happens, we call this as an adverse drug reaction. Now, what is the difference between adverse event and an adverse drug reaction? Because very often, when this harm, any unintended effect, or noxious effect, discomfort that happens to the patient, we are not able to at the first go able to define whether this is due to a drug, or is it because of the underlying disease condition of the patient, or is it because of some other extraneous reason. So usually, all of you are participating in the quality improvement initiatives in your hospital, so you are supposed to report these adverse events and adverse drug reactions. So at the first go, whenever any injury happens to the patient because of our medical management, it is called adverse event. There is no you don't have to define whether this is due to a drug or not, disease. Any injury which happens to the patient because of our medical management. I'm not talking about the complications which develop over a time. I'm not talking about seriousness of the disease here. We are just talking about any injury which was preventable but happens due to our management in the hospital. So it may be due to a drug, or it may not be due to a drug, but more than 60% of the management of the patient is with medications. So if it is because of the medication, then we call it as a adverse drug reaction. When we Can you go back, Annapurna? Uh, the This does not include overdose or non-compliances here. There is a causal relationship. When I say causal relationship, I mean there is a temporal relationship between starting a new medication and the timing of appearance of a new symptom or a sign. So if matches with that, the new symptom or a sign develops after starting a particular medicine, then we call that there is a causal relationship, and it could be an adverse drug reaction. Largely, as I said, adverse drug reactions are non-preventable, but certainly you can reduce the harm caused by these adverse drug reactions due to early detection of these in the and taking care of these in early in the management of the patient. Next. Okay, we call them serious adverse events, SAE, when it results in death or a life-threatening, patient needs life support, ventilator, or you need to admit the patient in the hospital because the drug caused acute kidney injury, so which requires hospitalization, or disability. It results in persistent and significant disability, incapacity, or if it also congenital defects or anomalies, birth defects are also included as serious adverse events. Next. Now, this is the universe of adverse events. As I said, adverse event is any injury that is happening in the hospital because of our medical management. Then you suspect some of this could be because of the adverse drug reaction, but only a smaller part of this is because of the adverse drug reactions. Now, let us see next. Medication errors. How do you differentiate between an adverse drug reaction and a medication error? Adverse drug reaction, as I said, this happens as a normal dose during, and this is part of the inherent nature of the drug. But medication error, as the name suggested, suggests that it is, harm happens because a drug was given in error, and then patient suffers an injury because of it. Medication errors are largely preventable. There is no need for the patient to suffer from harm because of the error, whereas ADR, you may have to, patient may have to tolerate this. Next. Now, why are we talking about ADR today? Is because next, because 40% of the patients, next, patients in the community, they experience adverse drug reaction. Whenever we are talking about ADR, most of the time we are talking about the patients who are admitted in the hospital. But let me tell you, the majority of the prescribing or the drug use, medication use takes place in the community, and quite a big number, more than 40% of these patients suffer from some or the other mild to moderate or severe adverse drug reactions. And 18 to 30% of the inpatients, those who are admitted in the hospital, also may experience adverse drug reaction, and they may account for more than 5% of the hospital admissions. Be careful, whenever a patient comes back to you, readmission within 1 month, majority people say that it could be because of an adverse drug reaction or a medication error. And out of these, more than 30% of the adverse drug reactions are severe, can be fatal for 1 in 1000 patients. So, we are concerned about ADR because they complicate drug therapy, decrease compliance of the patient, and delay cure. Because if the patient is having unpleasant side effects, nausea or diarrhea or a pain, so they may not take their medicines and may not complete their treatment as required. And sometimes, particularly when it comes to antibiotic, cancer treatment, chemotherapy treatment, it may result in delay in cure. And increase the chances of developing antimicrobial resistance, and of course quality of life is decreased in these patients. Next. So now, before I go into this, let us, because all of us think, are very much as a MD pharmacology student, also as a MBBS student, we used to रट लेते थे कि ये साइड नाउजिया वॉमिटिंग डायरिया सब में बोल दो, ऐसे बोल दो, तो it will take care of it without understanding what they are. Briefly I'm going to give you the principles behind how do you identify which drug can lead to which side effect. If you understand that concept, then you don't need to mug up these adverse drug reactions. So very often we classify these adverse ADRs according to the onset of event. It could be acute when it happens within 60 minutes of starting a medication. It could be latent when there are more than 2 days. It happens 2 days after starting the medication, and subacute is in between 1 to 24 hours. So these terminologies are important because if we don't use them properly, it can lead to mismanagement of the patient. Now, based on frequency also, sometimes we classify, we very commonly use very common. When we say this ADR is very common, it means more than one in 10 patients will suffer from this side effect. Common is 1 in 100. Uncommon is 1 in 1000. Rare, when we say, it is 1 in 10,000, and very rare is 1 in 1 lakh patient. So I hope this is clear, because the frequency is also important, so that we can look for these adverse drug reactions when we are starting these patients. Now you can also classify these ADRs based on the duration, whether it is a temporary discomfort, or a unintended effect, or a permanent effect. It may lead to some eye changes, or changes in the retina, or changes in the liver, or the changes in the kidney. It could be permanent, or congenital effect could be permanent, but temporary when they resolve over time when you stop the drug. Then Another way of classifying ADR is the severity of reactions. It could be mild, moderate, and severe. We say mild when it is bothersome, patient notices that, but it requires no change in therapy. Patient says, okay, it's tolerable, I can continue, this drug is essential for me, I can continue with. So you call it mild. But severe when it is disabling or life threatening, you need to stop that medicine for this patient, otherwise it will be disabling or life threatening. Suppose acute kidney injury is happening and all that, you need to stop this. So moderate is something, most of the patient here the patient would require change in therapy. Either you have to reduce the dose, or discontinue the drug, or start with the something alternative treatment. For example, one of the very good examples of this is, you all must have prescribed enalapril, lisinopril. Cough is a very prominent side effect of these ACE inhibitors. So as you increase the dose of these ACE inhibitors, the cough intensity increases. Very sometimes patient says, okay, there is some cough, I can tolerate it, so you can continue the same drug, same dose or same drug. But if it is bothersome, causing discomfort, then reducing the dose would relieve the patient of this cough. So that's when we will call it as a moderate. Next. Seriousness. Now there is also, you must understand that there is a difference between serious and severe. Very often we interchangeably use these words, serious and severe. Severe is, based on intensity. This is a measure of the intensity of an adverse response, whereas seriousness is based on the outcome. I'll give you an example. Migraine headache could be severe because it is based on intensity, so you will call it as a severe headache. Whereas chest pain, angina pain, would be serious because it is based on the outcome, because it is resulting into the harmfulness, tells you about the harmfulness of. So please be careful when you are using these terms, serious and severe here. Next. Next. Uh, I think you, okay. I think some of these. Okay, some of the common exanthemators, cutaneous allergic reactions are very, very common. So we use this word exanthem, urticaria, and fixed drug eruptions. So I have pictures here. So I think these are self-explanatory. So you can make out what is the difference between exanthem, urticaria. Urticaria, raised papules, and fixed drug eruptions are, fixed. Every time a drug is given, they will erupt at the fixed places, so these are called fixed drug eruptions. Most of these times these allergic reactions are not very life threatening. But next. But some drugs can lead to serious drug rashes, such as toxic epidermal necrolysis, Steven Johnson syndrome, and drug hypersensitivity syndrome, where patient will have fever, rash, or internal organ involvement would be there. These are life threatening drug rashes. If it happens, it needs immediate attention and treatment. If the offending drug is not identified in time, it can lead to constipation.
I'm not audible.
Uh,
Yes, ma'am, audible now.
okay. Then severe, in the severe category, all hypersensitivity reactions are categorized as severe ADRs. For example, anaphylaxis is example. Here there is a classic severe reaction with shortness of breath, respiratory distress, and hypotension is there. Usually onset is seen within, few seconds of within few milliliters of an infusion which happens. Now these are called severe ADRs, and serious too, because they can be life threatening. It begins with, it starts with angioedema, and then there can be a blockade in the larynx, and the patient may die. And the significance for you in your clinical practices is where it is important to recognize that this happens immediately after a medication, and patient can be saved if right treatment is offered immediately. Right treatment here is adrenaline, and it will save the life if given within 3 to 5 minutes of occurrence of a hypersensitivity reaction, anaphylaxis reaction. If adrenaline, and very often it is said adrenaline will be able to save if it is with you in the crash cart. That is why all crash carts should have adrenaline with you, because there is no time to go around and look for adrenaline, because you just have a window of 3 to 5 minutes to save the patient here, those who suffer from anaphylaxis. Next. So now this another way of classifying ADR, I think this will help you in understanding the in early identification, anticipation, and early identification of these. Are there are six different types of ADRs classified here. Type A, they are called type A, B, C, D, E ADRs here. Type A, it stands for augmented reactions. Augmented here, the meaning here is that these are related to the exaggerated pharmacological effect of a medicine. So whatever is the effect of the medicine, if it is the response is exaggerated, it is called type A reaction. For example, in hypertension, you give antihypertensive drugs to bring it to normotension. Now, from normotension, if the blood pressure lowers down, goes below that, it is called hypotension. So, hypotension would be type A reaction. So, it is usually seen with antihypertensive drugs. Similarly, for hypoglycemic drugs, they are given for hyperglycemia. If there is, exaggerated response here, so first, euglycemia will be achieved, and then hypoglycemia will be there. Similarly, bleeding, drugs given for bleeding. So I don't know, some of the people are writing that they cannot hear. I hope it is clear for others. Those who are not able to hear, maybe try logging out and logging in, or check your audio settings here. So these type A reactions, augmented reactions, are very common. They are predictable. You can predict it, depending on the class here, and they are dose dependent. If you increase the dose, the effect exaggerated response will appear. For example, bleeding, heparin, you give in small dose, it will not lead to bleeding event, but a higher dose of heparin will lead to a bleeding event. So you can predict this, and it is dose dependent. So careful dose titration will help in mitigating these adverse drug reactions. Similarly, there are several such examples. I hope you will be able to identify this if you know that it is the exaggeration of the pharmacological effect. So the treatment here, management here for this type A ADRs is that you reduce the dose, or you withhold the drug, or consider effects of concomitant therapy. Now, two drugs with the similar effect, for example, you have put the patient on aspirin and is also receiving warfarin, you can understand the effect will be additive here. Both warfarin is an anticoagulant and aspirin is an antiplatelet agent. Both will manifest as bleeding event for the patient. So you have to look at this from that angle, and these can be managed. Next. Then second type is type B, bizarre reactions. That means they are called bizarre because they are unexpected, unpredictable. You cannot predict it. Usually they have genetic predisposition, often are serious, but they are rare. As you know, one in thousand. When I said rare means one in thousand. Was it one in thousand? 1 in 10,000. Very rare would be 1 in 10,000. So these are rare, and usually there is no reason for this. These are classified as idiosyncratic or immunological reactions, all anaphylactic reactions, chloramphenicol induced aplastic anemia, malignant hyperthermia seen with anesthetics and antipsychotics. They are all classified as type B reactions. Here the management is withhold and avoid in future. There is no point in continuing these. This can be life threatening for the patient, because this anaphylactic reaction can be life threatening. Next. Type C is on chronic use. When you continue use of these medicines, per se they don't have these adverse drug reaction, but when you continue using them, these effects may appear on kidney. For example, gentamicin is a very common example. If you give short courses of gentamicin, it may not be harmful, but continued use beyond 7 days, 5 to 7 days, the patient may suffer from ototoxicity or renal toxicity. Then similarly, ethambutol induced optic toxicity. If you continue ethambutol, they may have visual acuity problems. Then bisphosphonates given for osteoporosis, they can lead to osteonecrosis on continued use. Again, uh, so uh, so another common example of chronic use is use of continued use of corticosteroids. HPA axis may be suppressed if steroids are given for a long time. So these steroids in short term may not be harmful, but when given for a long term, their harmful effects may be there. Again, the management involves that you reduce the dose or withhold, and withdrawal. Particularly for corticosteroids here, if you sudden withdrawal can lead to ADR, but if you withdraw slowly over a prolonged period, these adverse effects may not appear. Next. Type D, delayed effects. These are dose independent. Dose independent. Type A is dose dependent. Here, there is no relationship between the dose and the effect. Timing. Because as the name is suggesting, delayed effect. Timing makes it more difficult to detect. Teratogenicity, for example.
कैसे पता चलेगा
Carcinogenicity.
आवाज आ
We
रही है
don't know. For example, with immunosuppressants, some leukopenia may
हमारा
appear
है
after some time with chemotherapy. So these are
कौन सा
all
ऑप्शन
examples of delayed effects. Often are intractable, difficult.
हाँ शेयर कर रहे हैं शेयर करूं अभी
Uh,
ठीक है
these are uncommon. Type D reactions are uncommon, but then when happen, they are intractable. Next. Type E is the end of use reactions. Nothing happens when the drug is being given. Patient is all right, but if you don't stop them properly, some of these drugs may then show adverse drug reaction. One of the very common examples is beta blockers. Because one of the bradycardia is one of the effect of beta blockers, but when you suddenly withdraw these beta blockers, the patient may get into tachycardia and the ADRs will be there. Similarly, benzodiazepine, diazepine, patient has been on chronic use of benzodiazepines, and when you suddenly stop this, because there is a physical dependence with benzodiazepine, the patient will then suffer from insomnia, anxiety. So that is why benzodiazepines are also withdrawn slowly. You don't stop these drugs suddenly. And also similarly for corticosteroids, if anyone who has received steroids for more than 1 month, you need to stop them slowly. So these drugs can be whenever the patients suffer from these ADRs, these drugs can be reintroduced, but then be careful that these need to be withdrawn slowly. Next. And last is type F, unexpected failure of therapy. This may happen because of the drug interactions. Very common example is oral contraceptives and the anti-tubercular drugs, anti-epileptic drugs. Whenever they are given together, they can lead to unexpected failure of therapy. There could be contraceptive failure. There can be breakthrough seizures in patients with anti-epileptic. These largely happen because of the drug interaction, because of their enzyme inducing effects in the liver. So for this management of this, you have to increase the dose of the drug here. Dose of anti-epileptic drugs may have to be increased. ATT also, you need to look into that. For oral contraceptive, if the patient is also having TB or any of these drugs, then alternative method of contraception should be selected. And per se, if you are worried about the drug interaction, any drug regime wherever there is these drug inducers are there, warfarin, these should alert you to these adverse effects. Next. Now, these are the some of the classes of the drugs which are most often offenders in ADR. Antibiotics are the one for two reasons. They have the side effect and they are used very commonly. Chemotherapy agents, anticoagulants like heparin, warfarin, aspirin, cardiovascular drugs, hypoglycemic agents. Nowadays diabetes has increased and many patients are put on these medicines. So hypoglycemia and other ADRs are very common. Antihypertensives, NSAIDs, diagnostic agents, and CNS drugs. More than 60% of the time, these drugs are involved in the ADR. Next. How do you recognize that these are ADR? So now you have the knowledge. What you can broadly classify them into the ADRs. Now, any symptom should raise a suspicion of an ADR if it appears soon after a new drug is started. So whenever you start a patient on a new drug, be careful. And it appears after an increase in dosage, or disappears when the drug is stopped, or reappears when the drug is restarted. Usually we don't do this. We stop the drug, and if it symptoms disappear, it is fine. But this is called de-challenge. Re-challenge is not usually done because it can be dangerous for the patient, because if the injury or the ADR is severe or serious, it can lead to harm to the patient. Next. So there are people who are at high risk of having ADRs, extremes of age, small children, elderly, those who are suffering from multiple comorbidities, so thus on multiple medications. They have end organ dysfunctions like liver, kidney damage. They have a prior history of ADRs, and the also, as I told you, the extent, the dose, and the duration of exposure also decides ADR. And some people are genetically disposed to getting more. They may have ADRs even with a small dose of a drug. Next. So management options, I already told you. The discontinue the offending agent. Usually, if there are, the patient is the but here you need to consider whether it can be safely stopped. Is it a life threatening, or there are reasonable alternatives? You know. So depending on that, there is no need to stop all the medications here. But usually the last drug which is added to the regimen is withdrawn first, so that usually because of the timing of the appearance of ADR, it suggests that the last addition to the treatment was the offending agent. So you can do this one by one. But with anti-tubercular drug induced hepatic injury, delay, in that you have to stop all the anti-tubercular drugs, because the three, out of the four drug regimen, first line regimen, INH, rifampicin, pyrazinamide, and ethambutol, three of them, INH, rifampicin, and pyrazinamide, all three of them are hepatotoxic. So any one of these can lead to this hepatic jaundice in these patients. So usually this appears within 2 to 4 weeks of therapy, generally seen more commonly in patients with age more than 35 years, those who have underlying hepatic disease, or alcoholic patients. They face more of these hepatic toxicity features than other patients. But then in that case, you stop all these ATTs for these patients for about 2 weeks, one week or 10 days. Once the liver function test come back to normal, usually less than times, then you can restart. So in this case, the anti-tubercular drugs are added one by one, step by step. So because ethambutol has the least hepatic toxicity, so ethambutol would be introduced first, then rifampicin will be introduced every 2 to 3 days, and then INH would be introduced. If the patient remains asymptomatic and the liver function remains within the acceptable limits, then pyrazinamide can be added. But usually pyrazinamide has more hepatotoxicity, and if the period of jaundice or the enzyme elevation was sudden and prolonged, then introduction of pyrazinamide should be done with caution. So that's how you manage these adverse effects. Because in why I discussed this anti-tubercular hepatotoxicity is because you cannot stop this treatment. It is there are no alternatives available with us. We have second line anti-tubercular drugs available with us, but they are more toxic, they are more expensive. So it is and INH is a very important part of the treatment. You cannot stop it. So that is why this step by step approach is followed. If still patient has some hepatotoxicity, then the second line drugs can be chosen. Usually these resolve over a time. Next. So this needs, these patients need to be followed up, re-evaluated. What is the course of event? Are there any delayed reaction, response to treatment? And if there are any specific monitoring parameters that can help, those should be monitored. Next. General rule you may follow is, whenever a patient suffers from an adverse drug reaction, stop all non-essential drugs, vitamins and other things which have no role or no proven value in the management. Those should be stopped. You never know which excipient used in the preparation can be leading to the allergic reaction. So stop all non-essential drugs, consider dose reductions when suitable, consider interactions, and particularly in patients with severe ADRs. Next. So waiting de-challenge helps. You allow the body to recover. The if liver functions, for example in ATT, were deranged, usually you stop when more than ALT is raised more than 5 times, and more than 3 times if the patient is also symptomatic. So you give the challenge, stop it for 10 days, 2 weeks, and then restart step by step, as I said. Next. So next, I think I have already. So once you have managed the patient, documentation and recording is very important. The case records of the patient should describe what is the what was the ADR, how did you manage, what was the outcome, and these need to be reported to the drug regulatory or authorities, under the accreditation programs, ANQUAS, NABH, JCAO, JCI, any all of accreditation programs mandate that these be reported, and it is the duty of the researchers. Next, there is a form. There is a reporting suspected drug reactions.
मैम आपका वॉइस ब्रेक हो रहा है.
नेक्स्ट स्लाइड अनुकुल.
नहीं मैम, ब्रेक है मैम आपका वॉइस.
नहीं, स्लाइड चेंज करिए.
हाँ मैम. मैम आपका वॉइस ऑडिबल नहीं है.
नहीं है, what do I do? दोबारा लॉगिन करूं?
अभी ठीक है मैम.
Okay, but slides have gone now.
मैम इज दिस ओके?
हाँ, नेक्स्ट मूव करो, स्लाइड मूव करो. हाँ, a suspected adverse drug reaction reporting form is there. The information has to be provided in this. These are available on the internet. Next. Now, this is reporting is important. Next. Because it helps us in deciding the usefulness of the drugs. Many drugs have been withdrawn from the market because of the reporting of these. And remember, I told you the thalidomide incident. So a lot of tragedies can be avoided if we report these adverse drug reactions. Next. The package insert, the warning, precautions, all this information comes from reporting of the ADRs. If we report, then only they are included in the package insert. For example, levofloxacin was launched in 97, and in 2000 new label was added. It can cause torsades. So it is important for the safety of or identifying the questionable drugs. Next. It is a humanitarian concern because ADRs can cause harm to patients, and it is ethical. If we know that this is because of a drug, we need to take appropriate actions. Next. But problem is next. Problem is that not all of the adverse drugs reactions are reported. Only 2 to 4% of the ADRs are reported, and only 10% of the serious ADRs are reported, because people assume that someone will report. So that is why reporting is very, very poor. Based on that, it becomes difficult, because this withdrawal or banning of a drug or change in the instructions, this should be data driven. Next. And it is important. Many people say, why is it important when it has been used everywhere else? There can be differences in the population because of the disease prevalence, genetic, Caucasian, Asians, Africans, they may be genetically different. Social, how we behave, how we take our drug intake behavior, cultural issues, that we take some kind of a diet, or some food fads are there. So healthcare systems, practices, they may be different in different countries. So that is why each country need to monitor the adverse drug reactions. Next. So, and then because of this monitoring reporting only, then only we can find out the causality, whether it is associated with the drug or is it just the incidental finding. So for that, there are a lot of steps to be followed. I think I just wanted to tell you that causality assessment is required. Next. Based on that, you can classify whether it is likely that this could be because of the adverse drug reaction, or is it unlikely, or is it definitely, or is it probable. So all that is done in the causality assessment. Usually, as I told you, when you are reporting, it requires what was the clinical presentation, time course, dose relationship, whether it was reversible on a D challenge or not, whether there is cross reactivity or cross allergicity. Cross reactivity here means, for example, penicillin. Many people are, those who are allergic to penicillin are also hypersensitive to cephalosporin. This may happen to the extent of 15% of the patient. So there are chances, suspect this, if there is a allergy history to penicillin, he may be cephalosporin may not be a good choice here. Those who report food allergies are also more prone to get drug allergies. So be careful when you have such kind of patients. So and then treatment and prognosis need to be documented, so that the complete information is provided to the drug regulatory authority. Next, for appropriate action, signal detection. Now, a very important question is, who should be reporting. Generally, it is believed that it is the duty of the doctors, but all healthcare workers, including doctors, dentists, nurses, pharmacists, anyone can report. Anyone can report. Just because if you depend on only one group of professionals, underreporting will continue. Similarly, many of us feel that it is the duty of the healthcare professionals only. But now patients also are important partner in the treatment. They also can report. So patients also should can be participated. They can give more descriptive information about the drug. Quality of life issues are much more commonly. Next, if you're talking about patient centered care, patients need to be involved in that. And although there may be differences in the way you perceive ADR or the patient perceives ADR, but generally, worldwide now, the experience says that it is good to involve patients, and they should also be participating in these reporting. Next. The CDSCO is the site. This is the site where the you can find this form, fill up these form. Now they have made it very easy. There are more than 700 and ADR monitoring centers in the country. There is a toll-free number also for reporting. You can use these. They have using now technology also to enhance, to make it easier for the people to report these ADR. Next. The reporting, as I said, spontaneous reporting, voluntary is voluntary, but often is under reported. But then next, that is why you need to next, enhance this reporting. Next, by ask. Next. Okay. Oh, sorry. Can you go back? Now, next. Next. Yeah. Many times people don't report because they think that they need to be very sure that this was caused by the drug. This is not necessary. Whenever you suspected that it could be an ADR, it should be reported. You don't have to do that causality assessment. this will be done by the regulatory authority. Sometimes people think that one report will not make a difference, but as you understand, if more and more people report, then you will have a good data driven decision, on to be taken on these drugs. And many times we also think it is too well known to report. How do you report so many ADR? Nausea, vomiting happens with all the drugs. Why should you be reporting? Some people are concerned about legal issues, because or they may not have time, or they think it is too bureaucratic. And some feel that feedback. I had reported ADR earlier, but I had never got any feedback on this. So many people have different reasons, but it is important that next, at least if you cannot report all of them, next, as Annapurna, next. Yes, here only. Don't change. Especially if it is a newly marketed drug, new drug, or where there is a serious reaction or interaction was suspected, and something which was not mentioned in the package insert, and you find that it should be reported. And if suddenly there is an increase in frequency, although the nausea, vomiting, for example, with opioids is reported, but you find that there is an increase in the frequency, then again it could be because of the quality issue, it could be because of the excipient that is was used in the drug. It should be reported. So any adverse reaction happening because of the overdose, error, or when you suspect that the quality of the drug is poor, these ADRs should be reported. Particularly when you suspect contamination, there is a questionable stability, defective component, poor labeling. Next. Therapeutic failures. You have given a drug but there is no response. Again, this should be reported in the ADR reporting form. Next. Uh, as I said, spontaneous reporting is not enough, because only 6% of the reports are submitted. So you need to do intensive monitoring. Intensive monitoring here means that you look for ADRs, specifically look for ADRs in high risk patients. High risk patients are extremes of age, patients with comorbid illness, patients who are on multiple medications. So at least if you cannot study in all patients, at least look for these in these patients for early detection. So here, for all inpatients, you can take 10 to 20% of the current inpatients, and look for these ADRs. For example, if you are 100 bedded hospital, so you must study 10 patients every day, at least the high risk patient, to identify these ADRs early. Next. So intensive some of the triggers, or clues that can help you in identifying ADR is, suddenly when you find a order in the clinical case sheet for sudden discontinuation. The drug was supposed to be given, continued, but suddenly stop orders are there, suddenly dose reduction orders are there, or there are orders for tracer or trigger substances. For example, if the patient suffered from severe hypoglycemia, you may order 25% or 50% glucose here, because normally it's 25%, 50% glucose is not indicated therapeutically. You use only 5%, 10% glucose, but higher concentration glucose, when you use, suspect that some ADR must have happened. Or sometimes you ask for special test, liver test, kidney test. These are the hints that the patient may have had some ADR, which has resulted in this. Next. So let us, what is the link between, why are we talking about ADR? Both ADR monitoring and STG are concerned. They have a crucial role in enhancing patient safety and quality. And, ADR helps in identifying and addressing the risk associated with medications, while STG will provide you guideline for standardized and optimal treatment approaches. The STG will tell you the optimum dose. STG will tell you the frequency, duration, and the cautions which should be applied in patients to avoid these ADRs. So, if in your continual efforts to improve patient care, you need to have both ADR and STG. Next. Standard treatment guidelines are, as you know, the other advantages of, both ADR monitoring and STG are evidence based recommendation here. ADR is data driven, and in STG you will find evidence based recommendations for diagnosis, treatment, management, and it brings consistency of care and help in standardizing the care. Then it optimizes the medication use by their appropriate selection. It will tell you that these it should be used in this patient, not used in this patient, pregnancy, liver disease, kidney disease, like that. So what is rational, what is irrational? And of course, as you know, standard treatment guideline is a tool for measuring the quality improvement. Whether you are making any improvement in the prescribing part or not, this can be evidenced only when you have a yardstick available. Yeah, and a standard treatment guideline is a yardstick, with which you can measure whether the diarrhea is being treated properly or not, whether pneumonia is being treated properly or not, whether the assessment of response is being done adequately or not, whether appropriate investigations were done, or whether the patients were referred appropriately or not. All these things can be done only when you have a yardstick, and the standard treatment guidelines serve as a yardstick for this. And of course, it improves cost effectiveness and optimal utilization of the resources in our health facilities, and all with without compromising the patient outcomes. Both ADR monitoring and STG will help you in optimizing the patient management. Next. So I think I can skip this. Standard treatment guidelines. Many of you must have attended the earlier sessions also. The unique feature is that it provides the non-pharmacological treatment as well. Most of us focus on the pharmacological treatment because this is not the only. Sometimes pharmacological treatment will be successful only when it is combined with non-pharmacological treatment. For example, you cannot control diabetes if the patient is not controlling diet. You cannot control hypertension if the patient is not changing his lifestyle. Similarly, some exercises are needed for the management of osteoarthritis or other painful conditions. So pharmacological and non-pharmacological treatment both are important. And assessment of response to therapy is also equally a concern. One is to identify these ADRs, and secondly is whether the dose is sufficient or not. When should too early a change in the treatment or too late, both will be harmful for the patient. Hypertension, sometimes we make very quick changes in the dose very soon, within 1 week of starting antihypertensive treatment. But if we know the pharmacology, we know that it takes at least 3 to 4 weeks time for its optimum effect, antihypertensive effect. So any changes made earlier than 3 to 4 weeks can lead to hypotension. So this ADR will appear, because we made it too early change in the dose. Similarly, diabetes, a new diabetic patient has come to you. You have started on hypoglycemic agents, and if you make too early changes in the dose, or you add another drug here because sugar is not controlled, this patient may later land into hypoglycemia. So assessment of response to therapy is also very important. When should you do, how much should you do, to detect these ADRs and other outcomes. And of course, patient education is very important. They are the partners here in the treatment. If they don't understand, if they don't adhere to treatment, many times this, for example, patients stop taking medicines on their own because they are so fearsome of some of the side effects. For example, rifampicin, pyridium, a urinary analgesic, if given to a patient, both these drugs cause orange red discoloration of urine. So they may get so frightened, okay, we went for some treatment and now a new problem has arisen. So they may stop these drugs. Iron tablets, the black green stools, some mothers get frightened. Oh, what has happened to my child, so they will stop giving this iron. So it is very important to educate the patient. I think I gave you one question also in the pre-test. This pregnant woman in third trimester who was treated for UTI was given pyridium. Pyridium is a urinary analgesic which causes orange red discoloration, and it was mistaken as antepartum hemorrhage, and she was, this is a real life case. She was admitted in the labor room for APH, and then later on they realized that this was the orange red discoloration that happened. So knowledge of these is also important, so that you can prepare your patients accordingly. If they are prepared, they will not be afraid, and they will continue. Adherence will be better. So patient education also becomes. So I think I'm getting late. Next, we can skip these slides. And prevent this prescribing cascade. Try to find out a relationship, and try to find a drug which does not cause ADR or has lesser ADR, rather than adding a new drug here. Next. Attempt de-prescribing from time to time. Try, whenever any healthy patient has having 4 or 5 drugs in the prescription, suspect that prescribing cascade has happened. So attempt prescribing. Usually the last one is when you are adding, patient is not responding, then make an attempt to withdraw the first one. Otherwise, very often it happens that patients keep on adding, the doctor keeps on adding. Mine was not complete yet. Annapurna, there were 1 or 2 more slides.
Ma'am has tried it, that's why. Okay, ma'am. We have tried with ma'am's Horai and I.
Next, next. Next. Okay, these are the 5 moments. Okay, follow up high risk patients. Next. Next. Reconciliation, medication reconciliation is one of the options. From time to time, do this reconciliation. What all medicines the patient is taking, and see if some of these can be withdrawn. Next. The discharge is a time when you can prepare the patients, provide all this information about the ADRs, and prepare them for do's and don'ts. Next. Public education materials can be displayed in the hospital, in the health facility, especially for antibiotics, fluid and electrolyte management, and all these and these forms can be made available to the doctors working in your health facility. Next. Of course, medications are double-edged swords. You have to, balance this cost effectiveness. Side effects should be reported. There is a toll-free number. You can report on that. Next. So, how dangerous a drug is depends on the skills of the prescriber. Next, so you can, while it is non-preventable, but you can minimize. Okay, next session would be on June 17th, and we'll be talking about rational prescribing and perils of polypharmacy. How do you balance, strike the balance between safe and effective medication use? And next session would be on resuscitation, CPR. It will happen on June 17th. Thank you for patient listening. Over to you, Anpurna.
Thank you, ma'am, for your wonderful session, which is on identification and management of the adverse drug reaction. Even I got the many inputs over the adverse drug reaction, how to find out, how to decrease it by doing the de-prescribing and all. Our next session is on post-operative care of cataract. I welcome Dr. Jolie Rohategi, Director, Professor and Head, Department of Ophthalmology, Guru Tej Bahadur Hospital, New Delhi. Ma'am has over 30 years of experience with interest in the keen areas like cataract, glaucoma, lacrimal, and neuro-ophthalmology. She has 50 plus publications in international and national journals on glaucoma, cataract surgery, acidia, syphilis, corneal opacity, etc. Also contributed for many chapters in the books of dermatosis in tropics, STG manual, textbook of family physician, and ophthalmic disorders in geriatric medicine. She was awarded with the Louis and Victor Rombo Medal and certificate for merit for the best paper of reflective sessions in AIOS in 2004. Ma'am, I request you to take the session on the postoperative care of cataract. Welcome to this STG lecture series. Ma'am, over to you.
Welcome, Dr. Jolie. I think I must say she has been associated with us and she's been contributing to standard treatment guideline, the book I showed you right from the beginning. And she's been actively contributing in the revision. And we could not have found a more appropriate person than her, who understands this concept of rational prescribing and the rational management. Over to you. Welcome, Dr. Jolie.
Thank you. Thank you, Dr. Sangeeta. You can hear me?
Yes, now very, very clear.
So I have to share my slides first. Okay. So I'll be briefly telling you about the post-operative care of cataract. These slides are not shifting forward.
I think Annapurna, can you do it from your end only?
No, I'll be able to manage.
Okay, हो जाएगा.
So basically,
मैम आप नीचे वो स्लाइड को पूरा स्क्रीन कर सकते हैं.
So cataract blindness in India is almost 80%. And cataract surgery is the most common surgery to restore sight. More than 64 lakh cataract surgeries are done per year in India. However, we still have a huge backlog of 4.9 million, and this is partly because of the COVID-19. Now, people have a very high expectation from this surgery, and the success rate in various studies has been reported to be 95 to 99%. Due to the huge success, the indication of surgery have increased, especially the visual indications. Previously, visual loss and visual problems in daily life were the reasons for cataract surgery. Nowadays, anybody having a unilateral cataract, having decrease in the stereopsis or decreased peripheral vision, or having any bothersome glare, or has symptomatic difference of refraction between the two eyes, they are also going in for early surgery. At the end of a successful cataract operation is not the end of treatment for cataract. Okay? A good post-operative care is as important as the care taken by the surgeon before and during surgery. So an excellent surgery can have a very poor outcome if the post-operative care is not adequate. Now, the post-operative care starts from the recovery room. The patient stays there for around 2 hours under the supervision of a nursing staff. And for any adverse event or any other symptoms which he may be having. After this, the surgical procedure which has been done on him is explained to the patient as well as his attendant. So many times we have small things to tell them that, that we were not able to put the lens, or there was a lot of problem with the pupillary dilatation, etc. So we tell them so that they are prepared for the outcome. Then detailed counseling is done. After the counseling, the patient who are admitted as daycare patients, they are discharged from the recovery room itself, while those who are admitted are sent to the ward to be discharged the next day or after 1 or 2 days, depending on the condition of the eye. Now, daycare surgery is a concept in ophthalmology where, because the patients are otherwise healthy, we are admitting them only on the day of surgery, early morning, and in 2 or 3 hours or 4 hours, they are discharged and they can go back home. Now, there are certain steps in the counseling, and these include cleaning, eye cleaning methods, do's and don'ts about the surgery, the various medications, the methods and instructions, follow-up schedule to be explained to the patient, when to resume various activities, and reply to any queries which a patient may be having. The eye cleaning methods are described to them in detail. Any sticky or crusted eye to be cleaned with cooled boiled water and cotton. So this is very important. We teach them how to boil and how to keep the cotton and water covered so that it does not become a source of infection. Clearly, only the eyelids from the clean only the eyelids from the outside. No water or cotton should be going into the eye. The face is cleaned with clean moist cloth, avoiding the area of the eye. Do not splash water into the eyes. Use disposable tissues to wipe the tears or spilled eye drops gently, or even to blow the nose. No cotton handkerchiefs is to be used. Am I audible?
Yes, yes.
Okay. So there are certain do's and don'ts after surgery. For at least 2 weeks after surgery, do not rub or touch the eye. Use eye bandage or eye shield for 1 day. Eye shield or pad may be used for 4 to 5 nights in case if the patient is likely to rub the eye or touch the eye while sleeping. Sunglasses have to be used throughout the day and for two purposes. One is to protect the eye, and second is to prevent the glare, which is usually there initially because we are giving cycloplegic drops. It is okay to look down or bend down to watch TV or to read. However, there may be some double vision, there may be some visual distortion, which will gradually improve. Sunglasses are to be used till glare due to pupillary dilatation disappears. So the patient can decide for himself that when he's not having any problems without sunglasses, he can take them off. For any ocular discomfort, a tablet of paracetamol can be taken. However, if the discomfort is severe, then patient needs to consult the surgeon. There is no optimal post-operative drug regime which is followed. Different organizations, different surgeons follow their own regimes. However, the main drugs which are used include prophylactic antibiotics, steroids, non-steroidal anti-inflammatory drugs, tear substitutes, cycloplegics, anti-glaucoma medication. Now, antibiotics are used prophylactically to prevent endophthalmitis, which is an intraocular infection rather, and it is a very serious complication of cataract surgery, though it is rare. And it is rare because with advancement, more and more steps are being taken to prevent infection during and after surgery. Now, this endophthalmitis, in spite of best treatment, will result in loss or poor visual recovery. So it is very important that we use antibiotics for its prophylaxis. Now, the prophylaxis is a two-stage process. The first is we are eradicating the infectious agent on the ocular surface and surrounding tissue so that no organism can be introduced into the eye during surgery. And this is done by using 5% povidone iodine just at the start of surgery. The second stage of prophylaxis is that we want the antibiotics to diffuse into the ocular tissues, including the cornea, aqueous, vitreous, to kill any organism that, despite disinfecting the surface, may have been inoculated during the cataract surgery. Now, this is important because we are pushing in a lot of irrigating fluid, viscoelastic, and instruments inside the eye during surgery. Now, what are the characteristics of an optimal periocular antibiotic? It should be bactericidal. It should have a broad spectrum of activity, especially against gram-positive organisms because they cause up to 94% of endophthalmitis. It should be a fast-acting agent so that it can kill the surface bacteria before the surgery starts. It should also have a good tissue penetration so that when administered after surgery as topical drops, it will enter into the eye and it will assist in killing the bacteria introduced during the surgery. Finally, it should have a very low toxicity. Now, according to the American Academy, the drug which is advocated to be used is the newer generation fluoroquinolone, moxifloxacin. This is started 2 hours prior to the operation, given 1 drop every 15 minutes for a minimum of 4 drops. Along with this, povidone iodine is instilled in the eye for 3 minutes at the start of surgery and then it is washed off. Post-operatively, the patients are instructed to use moxifloxacin eye drops 4 to 6 times a day without stopping or tapering until the epithelial surface has healed, and typically that takes around a week. Tapering of antibiotics is not advisable due to development of resistant organisms. Now, something about moxifloxacin drop. It is a broad spectrum antibiotics. It is effective against gram-positive cocci, including MRSA, and selective gram-negative bacilli, including Pseudomonas, which are the main causes of post-operative endophthalmitis. In an Indian survey, it was found that 90% surgeons are using topical moxifloxacin pre-operatively, 1 to 3 days pre-operatively, and 94% are using topical antibiotics post-operatively, of which 78 are using moxifloxacin, 40% are using for 4 weeks, and 32% are using for 1 week. Role of oral antibiotics is gradually decreasing. Previously, we were giving a lot of antibiotics. Nowadays, with good asepsis, with good OT preparation and sterilization of instruments, better techniques, the incidence of infection post-surgery is really come down. And therefore, people have realized that oral antibiotics may not be required if you are giving topical as well as pre-operative topical antibiotics, except in cases of high risk, like if there is a posterior capsule rupture during surgery, if there is a vitreous loss during surgery, if the surgery is too prolonged, or difficult. There is a lot of iris manipulation. There is a corneal surface disorder. Patient is above the age of 80 years, or it is a immunocompromised patient. These are a group of high risk patients where we give oral antibiotics, either ofloxacin 200 milligrams BD or ciprofloxacin 500 milligrams BD. This is started on the day of surgery and it is given for a period of 3 to 5 days as an additional prophylaxis against endophthalmitis. Intracameral antibiotics are antibiotics which are injected into the anterior chamber at the end of surgery. Now, ophthalmologists have begun to use intracameral antibiotics in conjunction with topical antibiotics to achieve the therapeutic anti-infective anterior chamber levels. Although vancomycin is effective against MRSA, it is a poor killing curve profile and a narrow spectrum of activities. And some studies have even suggested that this can cause cystoid macular edema post-operative period. The European collaboration study found a significant reduction in the rate of endophthalmitis when using intracameral cefuroxime at the conclusion of surgery. However, further studies showed that it did cause some inflammation of the anterior chamber and rarely it can cause anaphylaxis. So the fourth generation fluoroquinolones such as moxifloxacin are now being used as intracameral injection in all complicated cataract surgeries. However, there are certain centers in India who are using this drug for all routine cataract surgery. The second group of drugs is the corticosteroids. This is the main drug to control the inflammation and it is used topically most of the times. However, if there is a very severe inflammation in the eyes, like some eyes with uveitis are very prone to severe inflammation, systemic steroids are also given. And they may also be given in complicated or high risk cases as discussed. The advantages of steroid is that it prevents inflammation, it hastens the visual recovery of visual acuity, it decreases the post-operative pain, and it is of low cost. Disadvantage, the main disadvantage is it increases the intraocular pressure, which occurs in about 8% cases. It can also impair wound healing and it also increases the risk of infection. The various topical and corticosteroids which are used include prednisolone acetate 1%, which is most commonly used. It is a suspension. Loteprednol 0.5% because it causes less IOP rise. Dexamethasone 0.1% is equally effective as prednisolone. However, the IOP rise is slightly more than prednisolone. The frequency of these above drugs is every 2 hourly on day 1 and 2 and followed by 6 times a day in the first week. And this is gradually tapered over a period of 4 to 6 weeks. So after, because that is the time for the inflammation inside the eye to be complete. So it takes around 4 to 6 weeks for the anterior chamber reaction to completely recover. Difluprednate is a relatively recent drug. It is very potent. It is required only 2 to 4 times in a day. However, it causes a lot of IOP rise. Now, the duration and frequency of corticosteroids is dependent on the amount of inflammation which we are observing on the slit lamp. So accordingly, we can modify the doses. Topical non-steroidal anti-inflammatory drugs, they are also used and they are in fact extensively used because they are used pre-operatively, perioperatively and post-operatively. Pre-operatively, they are essential for maintaining the pupillary dilatation during surgery, without which the modern cataract surgery will not be possible. They also reduce the post-operative inflammation. And most important is that they reduce the incidence of cystoid macular edema when combined with corticosteroid post-operatively. And cystoid macular edema is another very important cause of poor vision post-surgery. In spite of doing a good surgery, you can land up with a cystoid macular edema, and that will decrease the visual recovery of the patient. Now, the various topical drugs used are bromfenac, nefafenac, and ketorolac. Now, again, there is no fixed regime for the use of these drugs. Generally, they are started 1 month follow-up period to decrease the incidence of macular edema, and also at 1 month we are tapering the steroids. So any rebound inflammation which occurs due to tapering of steroid, that can be taken care of by NSAIDs. Now there were various studies where they have studied the compared NSAIDs to steroids for the post-op inflammation. However, though a lot of studies are saying that NSAIDs are good, equally effective, but by and large, they are not as effective as steroids. Hence, we cannot do without steroids in post-operative cataract cases. In cases of high risk, like posterior capsular rupture or vitreous loss, or if there was a cystoid macular edema in the other eye, NSAID, these drugs are used immediately after surgery, and they can be given for 3 to 4 weeks. The side effect of these drugs include corneal melt. They increase the dry eyes, and there is a discomfort on installation of these drops. And of course, they are definitely more costly than the steroid drops. The next drop which we are using are cycloplegic. They are dilating the pupil as well as relaxing the ciliary muscle. And their function is that they place the iris at rest during the healing process in the initial 2 to 5 days following surgery. They also help in managing the post-operative inflammation. We also need cycloplegic for a detailed fundus evaluation after surgery. They may also be required for refraction and for assessment of placement of IOL on the slit lamp to look for any decentration or any complication of IOL placement. Like if it is a toric IOL which corrects the astigmatism, sometimes it rotates and the patient does not have good vision. So that all that has to be assessed by dilating the pupil. Ideally, the short-acting cycloplegic drugs like tropicamide 1% are used. They are used for almost all the above indications. However, stronger cycloplegic drugs like homatropine, or atropine may be used if there is a very severe inflammation or if the patient even develops infection. Post-operative dry eyes is another very important cause of discomfort, and this discomfort ranges from foreign body sensation to stinging. It can last from 2 to 4 weeks, but it gradually improves. The cause of this dry eyes is because of the surgical stress to the eye including corneal nerve injury, irritation from repeated cycles of drying and irrigation intraoperative, phototoxicity from the microscope use, and toxic effects of the post-operative cataract drops, which are many in number. It is more pronounced in patients with pre-existing dry eyes. So there are various treatment modalities for this dry eye. First and foremost is that you avoid environment or substances including smoke, dust, direct air conditioning, as well as limited screen time, alcohol intake, or cigarette smoking. Apart from this, the first line therapy consists of copious artificial tears. Copious means it can be used 4 times, 6 times, 8 times, 1 hourly, depending on the requirement of the patient. But preferably we use preservative-free drops like carboxymethylcellulose 0.5%, or 1% CMC gel, or we can also use ointment. These treatments lubricate the ocular surface and they help augment the tear film that has become dysfunctional due to dry eyes. Now, preservative-free eye drops, they lack the toxic effects on the ocular surface caused by the preservatives. And therefore, they can be used at a much higher frequency as compared to drugs which have preservative in them. If all this above does not help, then we can give a 2 to 4 week regime of topical cyclosporine. There are various causes of developing increased IOP, or we call it as secondary glaucoma during cataract surgery. And the first and foremost is retained in ocular viscoelastic devices. And this is the most common cause, and this occurs in the immediate postoperative period. Now, these ocular viscoelastic devices are they are like methyl cellulose or HPMC, and these are used to maintain the anterior chamber during surgery. And it is very important that we remove it completely before we end the surgery. So, especially if it is not a very experienced surgeon, they are likely to leave behind some of these viscoelastic in the eye after surgery, and that can cause glaucoma, varying from very mild increase in IOP to almost a pressure of 60 millimeters of mercury. The other causes include pre-existing glaucoma, prior glaucoma surgery such as trabeculectomy, highly myopic patients, and also difficult cases which are requiring extensive tissue handling, prolonged surgical time, any intraoperative complications like posterior capsule rupture, vitreous prolapse, sulcus placement of IOL. Ideally, the IOL is placed in the capsular bag, but if there is any problem with the capsular bag, if there's a PC rupture or other things, then the same lens is implanted into the sulcus, that means space between the posterior capsule and the ciliary body. And that can cause persistent glaucoma, which can last up to months. Patients can also have steroid responsiveness to the use of steroid, and that can raise the IOP between 10 days onwards. So some people, if they are having high steroid responder, it can occur in 10 days. And in moderate responders, it can take up to 4 to 6 weeks also for the effect to come. However, this is transient if we are able to control the IOP in time, and it also needs early tapering. So these are steroid drops are replaced by non-steroidal anti-inflammatory drugs. Now the retained OVDs, they cause a transient rise, which usually resolves in 24 to 48 hours. People who have a healthy optic nerve, that means they do not have glaucoma or they are not glaucoma suspect, they can tolerate these spikes well. However, patients who have glaucoma or have a tendency to be glaucomatous, these spikes can cause additional damage to the optic nerve. So if the IOP is 30 millimeters or above, anti-glaucoma drugs like brimonidine, timolol, or dorzolamide is started. In case the pressure is extremely high, we can give oral acetazolamide, or even intravenous mannitol is required in some cases. Now, most of these IOP lowering medications is not needed for more than a week, and it is discontinued at the next follow-up after we find that the IOP is well controlled. So this was about the drugs. Now there are certain instructions which are very important for proper use of drugs. First is the method of opening the eye drop bottle without touching the nozzle. If a nozzle is touched, you are likely to cause infection and that infection will go into the eye. Then second is method of eye drop installation. A single drop of medication is to be instilled because most of the patients do not know, and sometimes they put 4, 5, 6 drops at a time, which is all wasted, and they will have to buy a new bottle within a day. So we tell them that single drop of medication is enough. The interval between two different medications should be a minimum of 5 minutes. The schedule of medication has to be explained to the patient because end of the day there are a lot of medications, topical medications to be put, and we also mark on the, because most of the patients are not educated, we put a mark on each medication to the number of times it has to be put, etc., so that the patient is not confused. No medication should be stopped without consultation, and do not allow others to use your medication. Method of instilling eye drop. The hand should be washed prior to installation. The patient should be sitting or lying with head tilted backwards. Gently pull the lower lid down with one finger. Squeeze one drop into the eye after shaking the bottle. This is important because the prednisone drops which we are using is a suspension. So if you don't shake the bottle, you will not get an adequate dose of the drug. Do not touch the bottle tip to the eye. It can cause trauma to the eye, and immediately recap the bottle after use. Now, when to resume various activity? It is a very important question asked by most of the patients. Avoid strenuous activity like sports, swimming, playing with children for at least 1 month. Avoid gardening and lifting for 2 weeks. Do not have a shower bath in the first 10 days after surgery. You can have a bath below chin only and use a wet, clean towel to wipe your face. Eye washing with normal water is not allowed for at least 10 days. Do not indulge in activities that might cause damage to your eyes. Do not lift heavy weights. If possible, avoid deep straining cough, sneezing, or straining hard for stool for a month. These activities may increase the ocular pressure. You can resume activities like watching TV or shopping after 2 to 3 days of surgery. You may resume all your routine household activities after a week. You can start using eye cosmetic only after 3 months of surgery, and cooking can be done after 1 week. Now the follow-up schedule. All patients are seen on the first post-operative day. This is the most important follow-up because that is the time when you are likely to pick up the early complications. Subsequently, all uncomplicated cases are seen at 1 week, 2 weeks, and 4 weeks. Out of these, 1 week and 4 week is more important. 2 week is not that important. Patients with some complications, which are either operative or post-operative, they are to be seen as and when required. As and when they are called for review, they have to come. Warning symptoms requiring immediate follow-up are explained to the patients. These include any pain, sudden onset of pain, redness, or defective vision. So either of the three, he should be very, very careful because these are signs of impending infection, and the earlier the patient comes, the better it is for him. Now the first follow-up is on the first post-op day. All patients are examined on the first day after surgery, whether they are for daycare or whether they are admitted or whether they go home. And this is to rule out any early post-operative complications, to diagnose any fundus pathology, which was not possible in pre-operatively due to the media haze, to assess the immediate post-operative visual outcome. The examination includes measuring the visual acuity with and without pinhole, slit lamp examination, fundus examination after dilatation of pupil. Particular attention is paid to, this is very important, the cataract wound, because it is a clear corneal wound these days. We are no longer doing extracapsular cataract extraction for routine patients. So see if the wound is well opposed. Look for the clarity of cornea, the anterior chamber depth and cellular reaction, the location and centration of the intraocular lens, and measure the intraocular pressure. A second operation is planned for those cases where there is a significant wound leak, there is significant retained lens matter, the IOL is decentered. Fundus examination is undertaken using a 90D lens to rule out any glaucoma or any retinal pathology. The patients are counseled again. We emphasize on the counseling. When they need to follow up, the post-operative medication regime is again explained to them, because surprisingly we find that almost 60% of the patients are using the wrong drops on the first follow-up. Patients are also advised to see the ophthalmologist immediately if they have the symptoms of pain, sudden onset of pain, redness, or decreased vision. In the event of a posterior capsule rupture or any complicated surgery, a more detailed examination is required on day 1. The presence of vitreous in anterior chamber, whether it is touching the cornea, whether vitreous strands are in the wound, for which we will need to do YAG laser vitreolysis. Then we may need to do a anterior vitrectomy, surgical anterior vitrectomy if there is a vitreous in anterior chamber. And detailed examination of vitreous is also required in these cases to look for any pieces of dislocated nucleus or cortical material, lens material in the vitreous cavity, because later on they will cause a very severe inflammation. The next important follow-up is the 1-month follow-up. And here the patient is, apart from the routine tests, which are same in all the follow-ups, patient undergoes a refraction and glasses or spectacles are prescribed based on their need, depending on the type of lens which has been implanted, whether the patient needs reading correction only or patient needs both distance and reading correction. So accordingly, he is prescribed glasses. Intraocular pressure is checked at this point of time because we are still using topical steroids, and then that can cause steroid-induced glaucoma. The eye is examined comprehensively for any sequelae following surgery, and the other eye is examined in order to plan the timing of cataract operation for the second eye. And some patients may be called back later than 1 month if there are any surgical or post-operative complications. These are the common complications. In the early period, you can have subconjunctival hemorrhages, which are of no consequences. You can have raised IOP, for which we need treatment. Retained lens matter may be present, which also may need correction. There may be severe inflammation. And for which we may have to give systemic steroids. Wound leak can occur, mild wound leaks. If the wound leak is mild, then it is corrected by just bandaging the eye. But if the wound leak is more, it is causing shallowing of anterior chamber, very low intraocular pressure, and you may need to resuture the wound. Dry eyes, of course, is commonly seen with in all stages. Intermediate complications include endophthalmitis, which is the most dreaded complications, retained lens matter, significant corneal astigmatism because of the incision. You can also have late complications, which the important ones are the cystoid macular edema, which is seen in 6% cases. And the most common complication following cataract surgery is posterior capsular opacification or after cataract. And it is seen in 12.9% of cases. And at 9 years post-surgery, 50% of the patients will have some form of PCO which requires treatment of YAG capsulotomy. Other complications include retinal detachment, glaucoma, and IOL related problems. So that is all. If there are any questions.
Thank you, Dr. Jolly, for such a simplified presentation. Let me share with the participants here. Although the topic looks very easy, but it was very difficult. Being a surgeon, it is very easy for her to explain the procedure, which procedure is better or not, but standardizing the pre-operative treatment and the post-operative treatment is a real task. And very often we come across these difficulties, and many patients keep coming to us with several questions: what to do, what not to do, what is right, what is wrong. And all these medicines, there are several medicines which are needed pre-operatively as well as post-operatively. And today it never occurred to me earlier, but after listening to you, Dr. Jolly, I realized errors can happen while applying the eye drops as well. And what if the patient is taking, because there are several eye drops and many of them may be looking alike, the patient may be putting some other drop instead of the one which was required. So I think thank you very much, for coming today, sparing time, and speaking to addressing our participants here. If there are any questions, she will be happy to answer. You can write in the chat box. Meanwhile, while they are writing, Dr. Jolly, can I show you? Can you stop presenting? I can show you the pre-test results here, so that
Okay.
once again you can answer the see how the response has been.
Okay.
I'll show you. I hope this time it is okay. Can you see my screen?
Yes.
Okay, good. So there were three questions on this. The commonest complication of cataract surgery is, this is how the responses have been. Green one is the correct answer. The gray ones are the wrong answers. Maybe you can once again emphasize on that.
Okay, yes. Because the actually, as I explained, that almost 50% of the patients after cataract surgery, especially this, we are doing extra capsular cataract surgery, they get a significant posterior capsular opacification, and that causes decrease in vision. So we have to do a YAG laser capsulotomy for them. Other complications, though they are seen, but they are not that common. See, they are only in the initial period, and then once we have treated them, they will not be like endophthalmitis. The incidence is only 0.06 to 0.4% nowadays with the advent of good pre and post-op care. So this is the complication which we are still struggling with. There are new lenses which are coming up, which are saying that there will be decreased incidence of PCO, but still the incidence is very high. The second question, anything else I have to tell about this?
No, just a minute.
Okay.
I think मैंने वो कर दिया इसको. Just a minute. Just a minute. The second question was which of the follow-up day is most crucial? Almost
I think I did it.
41% said
Yes.
it correctly, first day, but some said second day, third day, and the seventh day. I think.
I think I did explain that, most of the immediate post-operative complications can be handled very well if you see the patient on day one. Otherwise, suppose a patient has an intraocular pressure of say 60 in the first day, you are going to miss it. And in 2 days, this patient may have a lot of damage to the optic nerve. So we would prefer that all patients are seen on day one post-surgery.
Okay. Then
The
third question was treatment after uncomplicated cataract surgery includes all except, correct answer is oral antibiotics. They are indicated. I think she has already emphasized on this. Maybe you can,
Yes.
do it once again.
Yes, because you see, till for a long time, we were giving lot of antibiotics, oral, sometimes intravenous, sometimes intramuscular, because everybody was scared for endophthalmitis. But now that people have realized that topical antibiotics also have a role, and because of the good surgical outcome, the sterility of the OT instruments, and very good surgical techniques, we are now having a very low incidence of endophthalmitis. So for that, we should not be giving antibiotics. And another thing noted is that if you are giving too much of antibiotic, then the organisms which are present in the conjunctival sac or in the surrounding tissues are the ones which are already resistant to that drug. So if you by chance develop an infection, they will not respond to the routine antibiotics. So therefore, we are avoiding using too much antibiotic, even tapering of antibiotics, because sometimes we are scared that when we are giving so much of post-operative steroids to the patient, topical steroid, there is an increased chance of infection. But if you weigh the development of resistance against the increased chance of infection, we don't want resistance to develop. Hence, we are gradually in the process of tapering or stopping the antibiotics, especially the oral antibiotics. And it is shifted to a good topical antibiotic and even intracameral antibiotics, which are injected into the anterior chamber in all the high risk cases.
I think she has adequately addressed this question. If there are any questions you would like to ask her, okay, there are few questions here in the chat box. This Dr. Harshpreet Kaur, she is asking, patient was operated with foldable IOL 3 months back, was seen with inferiorly displaced IOL and haptic was in pupillary zone. PC was intact, and can IOL be replaced at 3 months post-op, or can there be additions of IOL with the bag? So patient should be referred to VR surgeon.
See, that can only be seen at when we are operating, because if the posterior capsule is intact, then we can always try and reposition this lens correctly. The anterior segment surgeon can do it.
I think
even at 3 months it is possible.
I think I hope are there any other questions? You can post it here. I think one of the take-home message. I don't know how many of you are ophthalmologists here. but I believe this group had always been a mixed group. Uh, you know, but how do you handle this ocular medicines? That slide was very, very useful. I liked it very much because this is a very common practice that we prescribe eye drops, and we don't tell that only one drop needs to be instilled and in what direction it should go. Otherwise, the whole of it goes waste, and there is no, the moment we put too many drops in the eye, nothing goes in. वो एकदम पेशेंट ब्लिंक करता है और सारा का सारा बाहर निकल जाता है. सो देर इज नो कॉन्टैक्ट टाइम एट ऑल फॉर द आई ड्रॉप्स. So those precautions are very much important. Prednisolone eye drops, which is a suspension, you need to shake it well, and give this instruction to the patient. Otherwise, the response may not be there. Dose of Adeline in anaphylaxis and root. I think we can discuss this next session. Is on CPR. I'll try to include this in the next session. Uh, I think.
Thank you, ma'am.
With this, there are no questions in the chat box, so we can conclude. You have a post-test link in your chat box, and a feedback form also is included is in the chat box. Please fill up the feedback as well. Over the time, we have found that the feedback is not being provided. This will help us in identifying the topics that you found useful for your practice. For this series, some of these topics were identified depending on our field experience and the type of patients you see in your clinical practice. So this feedback is also very useful for us to review this. So kindly finish this post test, and also if you want any specific topic to be included, you can write here, so we can try and find out if those topics can be addressed here in one of the sessions in the you
Thank you,
can
ma'am.
suggest. I was thinking in pharmacology or in rational use of medicine, what else to be included. We have had 9 sessions, 9 different topics I have already taken. If there is anything that you want to know in your clinical practice, which will be helpful for you in rational prescribing, I'll be happy to take. Thank you, Dr.
May I-
Jolly. हाँ बोलो अनुपूर्णा, you want to say something?
Yeah, ma'am. Shall I conclude, ma'am?
हाँ, कर अभी पोस्ट टेस्ट कर रहे हैं तो
हाँ, ma'am.
हाँ, आप वैसे हाँ कर दीजिए, फॉर्मली क्लोज कर
Fine.
सकते हैं. Yes.
Okay, ma'am. Fine. Okay, thank you, ma'am. Thank you on behalf of NHSRC. I thank Dr. Jolie Rohatagi and Dr. Sangeeta Sharma for conducting the session and sharing your valuable knowledge on the treatment protocols and management of post-operative care, and also identification and management of adverse drug reaction, which is very important for nowadays, even for reporting and all. I also thank Major General Professor Atul Kotwal, sir, Executive Director, NHSRC, and Dr. Jain Srivatsav, sir, Advisor, Quality and Patient Safety Division, for the support, for their continuous support to conduct the every month lecture series, which is conducting through virtually, and it is getting very helpful to all the participants, because I am getting continuously mail from the participants that they need access for the YouTube, and even they need some more PPTs for them to go on through that. So I'm getting continuously requests from the participants also. I'm very happy for that, ma'am. And finally, I extend my thanks to all the participants who are there even from the first session of the lecture series till today, and for the new members who are joined today. Our next session is on 17th June 2023, third Saturday of next month, on the topics of rational prescribing and the perils of polypharmacy, and also the technical session on resuscitation, that is CPR. So we will meet on the next third Saturday, it's on 17th June. And for the For this session, you can access the whole YouTube session is got in YouTube's link that we have shared in the chat box. You can go with that, so that after 4 days or 5 days you can access this recording through the YouTube link. So finally, I thank everyone, so that we are going to conclude. If anything is there, you can mail us stg.webinar@nhsrcindia.org, and we will be get back to you through the mail. Thank you, one and all. Thank you, ma'am.
Thank you, Dr.
Thank
Jolly,
you.
for joining
Thank you.
us.
Thank you.
The session is on. Please fill up the post session quiz. We've just got 36 responses so far. This is a requirement. Sorry, this is a requirement for issue of the certificate. Somebody was asking about the credit hours. I think it is in your own interest that you get this. Maybe right now this is not a compulsory requirement, but this is a self-learning, self-continuing education process that we where we try to upgrade our skills regularly, or refreshen. If not, if it wasn't upgrade, at least we are able to refresh our knowledge, from our pre undergraduate days and postgraduate days, and many of us get alienated, I get isolated, being in the peripheries, don't get many opportunities to attend continuing medical education programs. I think this endeavor was in fulfillment of that, so that you don't feel isolated. You get access to the current guidelines, or the what is happening latest in that field. With this, these topics were I hope we are able to fulfill that goal, that we envisaged while planning for these sessions. And I think COVID was a blessing in disguise in this regard. Otherwise, physically, it is not possible to have so many sessions with so many participants uh, with us. Dr. Jolly, normally we have around 250 participants. Today there weren't many. Maybe, I don't know what was the reason. It is a vacation time or something. But being an online program, we could reach out to so many people. Uh, so I hope with your continuing support, we'll be able to do it. See you next time, June 17th. You can write down the topics here which you would like us to be handled. One of you had written UTI or heat stroke. We will see in the next series if we can include these. We'll find a place for these sessions. I think, Annapurna, we can leave.
Yes, ma'am.
Leave.
Yes, ma'am.
I hope all of you have opened the post test link. Otherwise, you will not be able to access this. So at least open this post test link and fill it up at your leisure time. But by tomorrow we will be closing the link uh, to the post test. So at least open it now.
Yeah, this is a mandatory to attend the pre and post test to get the participation certification from the NHSR.
Next time, Annapurna, I was just thinking if we can apply for credit hours from the medical council also. So that will
Okay.
increase the uptake. And those of you, we must also identify people who have attended all the sessions.
Sure, ma'am. Sure. We have a complete list who is attending since that day
Yeah,
one.
those who have been attending right from the day one. Today is the 9th session. Mm.
Yes, ma'am.
A YouTube link will be posted. You will receive after 4 days. जिस चैनल से आपको ये इन्फॉर्मेशन मिली, उसी चैनल से आपको YouTube लिंक भी मिल जाएगा.
Yes. Once you can subscribe to the YouTube channel so
I
that you
want
can
to
see.
know one more thing from the participants here. How did they get this information about the program? Is it the WhatsApp? Is it the email from NHSRC or email from DSPRD or word of mouth? Mail, okay. Mail from?
Accidentally got it.
Accidentally कहाँ से मिल गया?
Discourse group, okay. District Health Official Group.
That's good one.
Okay.
Why am I asking this? Then you can be included in the mailing contact list so that you don't miss the next sessions, while searching something else. Okay.
LinkedIn
Which social?
profile.
Okay. Okay.
Yeah, you can
Diagnostics
access to
leadership.
LinkedIn profiles also.
Okay.
Every month we are going to update even in the LinkedIn profile, in NHSRC website, even in DSPRUD से भी mail आता है. Even from STG webinar NHSRC से भी mail आता है आपको who are registered under this.
Chalo. So all channels are working actually. So we should continue using this. Okay, please explain meaning of 7 points or 4 points in your MCQ test. Yes, some of the questions had the check boxes where more than one option was correct. The question which had, maybe if you are there, I can show you, share my screen and tell you what does it mean. Just a minute. Uh, quickly you can see this. The question I was discussing about the preparation of the patient, about the side effects. Pyridium, which is a urinary analgesic, leads to this orange red discoloration. This was the correct answer. The not a very common type is delayed reaction, but type A is the most common reaction. Type B are hypersensitivity, allergic reaction to a medicine. This was the correct response here. Now here, the 4 points. This question had 4 points because all of these factors are important. They increase the risk of adverse drug reaction. Advanced age as well as neonates, polypharmacy, chronic disease. These are all the high risk factors which can increase the risk of ADR. So those of you who have answered correctly, checked all the 4 options here, will get 4 marks. Others will not get it. So although varying percentages have given this correct responses, but you will get 4 marks only when all 4 options are selected. Then similarly here, which of the following is an important step in identifying ADRs? Is, when you monitor patients for signs and symptoms of ADR, when you are looking for it, then only you will find it. If you are not looking for it, you will not find. This is a human psychology. We will see what we want to see, we expect to see. Anything, if we need to train our eyes to look for these ADRs. So around 50% of you said yes. And medication reconciliation also helps you in identifying, preventing, because the question is about identifying. If you can identify what are the duplicate medicines here, the drugs which can have interactions, which unnecessary drugs which are there in the patient's prescription. So these will help you in identifying the ADRs early here. This question was about important step in managing adverse drug reactions. So how do you manage? Either you monitor the patient closely for recurrence, discontinue, reduce the dose, and then take preventive measures to avoid So timing of that drug is important. With food, without food, empty stomach, those preventive measures, if you can take, for example, painkillers. Very often nowadays, anyone who prescribes, even for the first time to otherwise healthy person, painkiller, they will prescribe this omeprazole along with it. Whereas omeprazole is not all the time needed. uh, Omeprazole would be needed only in high risk patients, elderly patients, those who are taking multiple medications, have alarm symptoms, or have bleeding tendency. It would be needed in only that. But अगर आप simple सा पेन किलर का आफ्टर फूड दे देंगे, that acidity will be taken care of. So these are the some kinds of preventive measures that you can take to reduce ADRs here. So those of you who had marked all three will get 3 marks for this. Then similarly in this question, what is the example of a healthcare profession who may involved in reporting and managing? So I was expecting this. Patients, only 20% of you have said. So patients are also important. So again, anyone who had marked all 5 options will get 5 marks for this. The intensive monitoring is, I said, at least you look for these ADRs in high risk patients. High risk patients, as I said earlier, are extremes of age, multiple comorbidity, on multiple medications. They are the high risk. The goal of the intensive monitoring is the early detection to minimize the impact of ADR. So this will be minimized only if you detect them early. Otherwise, it will be late. Sometimes it may cause permanent harm, or temporary harm, but which requires intervention. So the goal is to early identify them early. Then I think I have already discussed this regarding hepatotoxicity. All of these are correct. Inactive carriers of hepatitis B. The statement was wrong here. Around 17% of you have correctly identified this. Inactive care, also checked on this actually, because they also have increased risk of ATT induced hepatotoxicity. So sometimes in these patients you may have to do the serology as well. Then which of the following constitutes an appropriate management of an adverse I think I have repeatedly covered this. Look, reduce the dose, stop it if you can, provide supportive care, provide use reversal agents. Reversal agents are, for example, if opioid toxicity overdose is there, you use naloxone. Or hypoglycemia is there, then you use 25 to 50% dextrose, like this. But rarely you stop all medicines, because some of the medicines may be required as maybe essential. The base condition of the patient may not allow for withdrawal of all these. And of course, this was also wrong. Continue all medicines at same dose. Otherwise, if it is mild, tolerable, fine. But if it is moderate or severe, then it can cause harm to the patient. Then role of pharmacovigilance is to identify and report these ADRs to regulatory authorities, so that they can modify the instructions, package labeling instructions, and take decisions on whether the medicine will stay on market or not. Banning decisions are taken based on these reports. I think these three have already been discussed. आई थिंक थैंक यू.
Thank you, ma'am.
पोस्ट टेस्ट कितने लोगों ने भरा है? लेट मी सी. 68
7, ma'am.
only. 68 only have filled up the post test. I hope they have opened. We can close the session. It's already almost 6 o'clock. This session was up to 5.
Thank you, ma'am. Thank you, Dr. Rajoli Rohategi, ma'am, and Dr. Sangeeta Sharma, ma'am. We are going to close the session now. Participants, you can even access this link later, and you can provide your feedback and also the post test. Thank you one and all.